That sounds good. Yep. All right, beautiful. Everybody, apologies. I thought I hit allow everyone in. I'm sitting here going, why isn't anybody coming in? Why is it Zoom letting me in here? Because I didn't press the right button. And yes, I have elf feet on my head today because that happens to be where the stockings are. I forgot that they were there. A little bit of Christmas, a little bit. I got a little bit on my watch, just a little. So welcome everyone. Thank you so much for being here today. There was like a weird delay in my voice and face at the same time. That was strange. Okay, so thank you all for joining me this morning. It is Tuesday. I'm a little off if I seem it. The kids have student teacher, parent teacher conferences today, so they're not at school, and that's just weird on a Tuesday. They're supposed to be in school, right? Kind of threw things off for me, but that's okay. Let's see. So, for anyone who does not know me, my name is Lisa Wasson. I am the community nurse educator for Hope Health. Hope Health is a hospice and palliative care agency based in Rhode Island and Eastern Massachusetts. Um, we cover certain parts of different counties in Massachusetts. So if you want more specifics on our Hope Health Co. website, there's a map that will show you exactly where we cover if you're interested. And my role is to develop continuing ed courses for healthcare professionals and teach them. So I teach them here online. You've seen here, so you've seen some of our virtual offerings, and I teach them in person. If you are in our coverage area and you have a work in a facility that would like in-person training, I can do that as well. And if you have topic suggestions, guys, if they are, so the sort of rule around it is it has to be something that we at Hope Health have experts on, right? It has to be in our wheelhouse as hospice and palliative care clinicians. But if there is, especially if it's relating to end of life care, reach out, put it on the eval at the end. There's a little spot at the very end of the eval that says suggested topics. We do take those all into account. We set up our calendar every 3 months. I call it by season because I'm not one of those folks who does the whole fiscal year stuff. I'm a nurse and a mom. So I set them up by season, and our winter season has just started. We have 2 new programs every season. They're not all taught by me, but I pull in other professionals when the topic is out of my wheelhouse and better for theirs. So if you're interested in any of those, please join us. All of our programs are approved for 1 CE for both nursing and social work for licensing. If you don't need that, but you need attendance, proof of attendance, our certificates are good for that as well. In order to earn the certificate or just receive the certificate, you have to attend the entire class, of course, and then complete the course survey after class. That will be emailed to you later today by one of my colleagues. It will come from an email. The name of the email is Community Education at Hope Health, and that will have a quick little link in it for a couple minute evaluation. Once that's submitted, we will send your certificate on to you. Okay, all of that is done. Now, I see probably about half of you have already done this, but if you have not, please put your first and last name in the chat. That allows us to track attendance versus the registration, because not everyone makes it. And the other gentleman you can see right now, the only gentleman you can see right now, I'm not a gentleman, is my colleague John. He's one of our wonderful volunteers, and he will keep an eye on the chat for me as well as taking attendance. If you don't give me your name, then you won't get the certificate because I don't know you were here, and I can't keep track of everybody. Need to please make sure that your first and last name are in that box. Okay, the chat box for me. All right, our program is, I do use a PowerPoint, so I'm going to find that for us. Where'd it go? There it is. Dun, dun, dun. Almost. Okay. My laptop's been a little finicky, so hopefully it's going to cooperate today. I have put in a request for a newer one that is more cooperative. So hopefully that will happen soon. Alrighty, great. If you are able to put your camera on for myself, honestly, that is nice to know there's a person there, not just a black dot to stare at. Um, I love seeing people's reactions and knowing that you're actually there paying attention to me. But I don't require it only because I know that some of us work in places where they don't want our cameras on because of our background and that sort of thing. But otherwise, if you are willing to, that would be wonderful. Okay, let's get started. Our topic today is understanding Parkinson's disease. So I had a request to put together a program focused on the unique needs of someone with Parkinson's disease at end of life. The human body dies. If we die naturally, the human body shuts down in sort of a particular process. But depending on the serious or terminal illnesses the person may be living with, life-limiting illnesses, changes some of it. Symptoms beforehand, symptoms that happen when they're actively dying, and then of course we also factor in the normal natural dying process. So I have some specific courses, um, disease specific about end of life. But I realized as I was developing that program that there was a lot I didn't really know and understand about Parkinson's, and I wanted to know more. I think that's why we're all here, is we want to know more, or maybe you just need CEs, and that's okay too. Um, so I wanted to put together an understanding the disease of Parkinson's, treatments, diagnosis, medications, interventions, those kinds of things. And then I also developed an end of life program related to Parkinson's disease. So I tried to do both, this being the first. The other one is offered soon, I'm pretty sure. But I'd have to look at the calendar. So let's see what we have here. What is Parkinson's disease? Many of you probably know this. I know it's sort of the basics, but just in case, Parkinson's disease is a brain disorder. It's a neurological disorder that causes unintended and uncontrollable movements. Okay, so it is because there is a deficit in the basal ganglia. We're going to talk about that part of the brain, where the brain is either not producing enough dopamine or it is not using the dopamine properly. And that happens to be the neurotransmitter in our brain that helps us control our movements. So when the brain is not producing or using enough of that in the right way, these unintended movements happen. Someone with Parkinson's disease will develop over time shaking, stiffness, tremors, difficulty with balance and coordination, ambulation, difficulty with chewing and swallowing, difficulty with managing, with writing or typing. Most of us are on computers more than writing these days, but difficulty with fine motor skills, difficulty with transfers, managing their way around their house or their office, their job, those kinds of things. Difficulty with bathing and dressing because their ability to control their limbs and the movements in their limbs increases, becomes more and more difficult. Okay. What does happen in the beginning is that the symptoms start gradually and unilaterally. So they start on one side of the person's body. There's no particular sort of fashion to whether it's the left or right side. I can't specifically say. It's usually the dominant side or anything like that. I don't have that data. But it starts on one side of the body, maybe a hand tremor, might be a foot or leg tremor. Even if it is a jaw or facial tremor, like a head and neck situation, right? We don't have unilateral, but the tremors would be, say, in one side of the muscles. Even though it might look like it's the whole head shaking, it's because the spasms or the firing of the muscles is happening on one side of the body at a time. As the disease progresses over time, it does transfer across midline and become a bilateral issue. But in the beginning, it is unilateral. If you watch any medical shows on TV, I don't know if you guys are anything like me. I like to watch them and catch all the mistakes, which is probably terrible, but I like to go, you can't do that. But you almost always see if someone on TV is developing Parkinson's disease, it's a tremor in their hand. I really think it's the easiest way to show it, right? And for an actor to portray that, but that's what we usually see. I feel like the hospital shows, it's always the neurosurgeon who does the most delicate work that develops a hand tremor and then can't operate, right? So anyway, I digress. It's just interesting. The reason I bring up things like that is this is what our clients think because that's what they know. They haven't had the schooling that we have, right? So they don't have anything to relate it to besides what they see on TV or the Google rabbit hole they go down with WebMD and Wikipedia researching things, right? And we all know now that the internet will take you whichever way you want to go, good or bad, right? Um, so we want to make sure that we are educating them properly from a clinician point of view about what to expect, what is next, what they might notice, what's normal and what's not, and those kinds of things. So, along with, I think very unsurprisingly, along with the physical issues, the uncontrolled and unintended movements that come with this disease, there's also the psychological challenges that come along with it, mental health challenges, depression, anxiety. Uh, I think we can all imagine that if we were unable to perform the tasks that we normally did very independently, we would have some difficulty with mental health, with, our emotions and sadness and fear and anxiety and depression are all very much expected when something like this occurs and there are major changes in someone's life. Behavioral changes can also become a part of it. Interestingly, things like being more short-tempered, more agitated, easily agitated, because of the frustration that they're dealing with not being able to control their movements and not being able to perform tasks independently. Also, there can be cognitive issues along the line, usually later on in the disease. Parkinson's will progress to Parkinson's type dementia, where there's a lot of memory, language, cognitive difficulty. It is slightly different because of the Parkinson's disease being the precursor of that type of dementia specifically, but it is in many ways similar to other types of dementia. Sleep problems, having difficulty sleeping, frequently waking, difficulty falling asleep. And of course, this can also fog the brain and cause memory difficulties and language difficulties, as well as fatigue. And fatigue not only mentally, but physical fatigue, because all those unwanted movements are still happening. Their muscles are still contracting and firing. So it is physically exhausting to have Parkinson's disease. And in many ways, many times during the day, they're trying to control those unwanted movements to do whatever task they're trying to perform. So their muscles are working extra hard to do that. Looking ahead at some risk factors, age is a risk factor. The older we are, the more likely or the higher at risk we are of developing some sort of disorder, Parkinson's being one of them. Typically diagnosed over the age of 65. But again, many of us know Michael J. Fox, the actor who was diagnosed very early on. He did have early onset. Um, um, and he's had a very visible journey. He's done a lot of work, of course, to raise money for treatment and cure, but also to show people what it's really like, to explain. He's written books about his life with Parkinson's. He's done a lot of interviews. There's a great one from the Sunday morning show, if you care to Google and see. I was just in awe of his ability to do it. First of all, to do that interview, but then to also be able to explain to us and the interviewer what it was like for him. So if you're curious, that's great. I'll talk some more about that later. Heredity. Yes, sometimes Parkinson's is hereditary. If there is a history of this in the client's family, they are higher risk of developing Parkinson's. Is that something that can be tested for? Also, yes. There is genetic testing for markers that would indicate someone is higher risk or likely to develop Parkinson's as they age. Gender is also a higher risk. More males than females tend to have this disorder. Um, we don't, I'll be honest, we don't have specifics on why, but I think maybe this next thing may factor in to the gender skew when it comes to Parkinson's disease is exposure to toxins. Um, there are herbicides and pesticides used by farmers, used agriculturally in past years that have increased the risk factors for that person that's been exposed to them. In I think we generally know and understand that more agricultural farmers are male than female. So I wonder, is that why more males than females develop this disorder? As we get away from generations who use those herbicides and pesticides, will it change? Will we then see more of a balance in the gender equation there when it comes to Parkinson's? Maybe. We're not there yet to find out. Give me just a moment, please. Open that real quick and get your stuff out. Please, real quick, Alexis, open it and get your stuff out because you're making too much noise with that, or go in the other room and do it. Thank you. Okay, sorry about that. So here, I wanted the simplest possible image to just give you an idea of where the brain is being affected by Parkinson's disease and the difficulty with dopamine production. So our dopamine in our brain is produced in the basal ganglia. That's the area you can see indicated. And it is also where that chemical, that neurotransmitter, is being moved around. It's made there, it's produced in that part of the brain and sort of shipped off to the other parts of the brain and the other parts of the body where it's needed. A neuron, so there's thousands and thousands of these little guys in that area of the brain, and the dopamine is taken in through that little bell shape at the end of the neuron there, and it's absorbed by the neuron and then distributed wherever it needs to be. So if the neuron isn't absorbing it properly, if the brain isn't making enough, we need to somehow substitute that in order to help control the unwanted movements and other symptoms that come along with the Parkinson's. Early signs, what might we see? I mentioned a number of these already: mild tremors, stiffness. So after lying in bed all night, stiffness getting out of bed, needing to take extra time to get up, more stretching to get comfortable and moving. This makes it more difficult to transfer, from lying to sitting, sitting to standing, walking to the bathroom and having, using the restroom, brushing their teeth. All of those transfers become more difficult. The movement is more stiff. You will notice, maybe not right in the beginning, but over time, changes in posture, changes in their gait, where they're more of a shuffling gait. You'll notice a softer speech. Now, maybe this person was soft-spoken anyway, so it's not as noticeable. But certainly, if this is someone like me, you will notice right away if my speech becomes softer, right? It's not something you're going to miss if I suddenly speak softer, if I were to have lack of facial expression, right? If my face was no longer expressive and very flat, you would all notice, people would notice in my life because I'm very expressive. Not everyone is. I had an uncle who was a very stoic man, and he didn't have Parkinson's, but I think of him when I think about this as like, would we have noticed that his facial expression was any different? Maybe not. Um, Handwriting, noticing that it changes, it's slower to write, and then the letters, everything is more cramped, much smaller letters, tinier penmanship than typical. This also, for myself, makes me think of my father, who wrote very tiny. He always wrote very, very tiny. So I don't think we would have noticed that difference. But of course, the other signs would have been more apparent, I think, for sure. Um, let's see, and unilateral changes, arm or leg movements, typically first, and then it can spread, sort of move and become bilateral. While I'm talking about this unilateral tremors or arm unwanted movements, there is a diagnosis um, called an essential tremor. And this can look like the beginning stages of Parkinson's disease. It is up to us to have our client see a neurologist to determine if it's more than just the tremor and it's actually Parkinson's or not. There's testing that can be done to identify that, but it does very much look the same as early stage Parkinson's disease. So that's good to keep in mind. My slide doesn't want to move. Give me a sec. There we go. For main symptoms that we see, the tremors, hands, arms, legs, head, neck, jaw, they can be very much, it's typically a little bit of a shake in the head, but it's very noticeable when it is happening in that part of the body. The muscle stiffness, which can lead to contractures. So that is a very important reason to keep our folks moving and stretching and active, because we don't want them to form contractures that are then, they debilitate. They are difficult to release. Even I was an occupational therapist years ago, and contractures are very difficult to work with once they have formed. So if we can use preventive measures, lots of exercises and stretching to keep them moving, we're going to sort of, I like to think of it as staving off the start of those contractures, keep them from happening early, right? Get them to be something we, keep them off so that we can deal with them later if they happen. Slowness of movement, yes, because of the Parkinson's and also because of the I don't want to say crises, I don't want to say symptoms, but because falls are common, bumping into things because of the uncontrollable movements, the poor coordination. So the slower they move, the safer they are. Okay, I couldn't think of a better way to sort of to say that than to describe it. But slower movements means they're keeping themselves safer as they're walking, holding on to furniture, holding the arm of someone that they're with in public so that they keep their balance better, shuffling their feet on the floor so they don't trip over things and their feet are in contact with the floor more than they're not in contact. So that's very common. And falls. Unfortunately, Parkinson's um, is a disease that really sort of tops the charts when it comes to clients falling because of Parkinson's disease. The way it affects their coordination and movement really puts this person at a very high risk of falling and unfortunately getting injured. Okay. Interestingly, when I was researching this, what I was not aware of is that we actually stage Parkinson's disease, much like we do with dementia. I do spend a lot of time researching dementia because that's a specialty of mine. So there are a number of different staging tools, but I was not aware that in medicine we stage Parkinson's. So let's take a look. I did put these stages in as simply explained as possible, but exactly the way I found them explained from a medical journal, so that I didn't adapt or change anything. These are the words and the way the stages were described. Okay. For myself and for you. Stage 1 in the beginning, mild symptoms, unlikely to affect their day-to-day functioning. A mild tremor I hate that word, I wish I didn't say it, isn't going to affect the day-to-day functioning of most people. If you're what was I saying? A neurosurgeon, yes, it's going to affect. If you are working on tiny computer pieces, right? Yes, it's going to affect your day to day. But for the majority of us, a mild tremor isn't going to interfere all that much. We will notice the change in posture, gait, and facial expression even early on. What happens with the posture is that the head moves forward, sort of like a turtle would push their head and neck out. The shoulders tend to roll forward or slump forward. The whole trunk of the body from the hips leans forward some. Often the hips are flexed slightly and the knees are flexed slightly, so that there's sort of a forward bend, almost the beginning of a sitting down chair position. And this is because the way the coordination area of the brain, the cerebellum, is being affected, the person with Parkinson's feels that their center of gravity isn't where it normally would be. When we are standing erect, shoulders on top of hips, on top of knees, right? Our head up where it should be, that is where our center of gravity should keep us most stable. But for someone with Parkinson's, in that position, they feel like they're falling over backwards, tipping backwards. So, in order to adjust for that, they lean and hunch forward, and that whole change in posture helps to keep them balanced more. And that's why they sort of almost curl up and bend some to be able to keep their posture, not their posture, but their balance better. Uh, Stage two, increasing symptoms, more noticeable to those who are not in their inner circle, their most close people, right? More noticeable to people they meet, to doctors in doctors' visits, to social situations. And it will likely at this stage begin to interfere with their daily life. I do not also, unfortunately, I don't like to say I don't have stuff for you, but much like dementia as well, I can't tell you how long stage one is going to last and how long stage two is going to last. It is different for each person, depending on, I mean, are there crises in between? Do they have a fall with a major injury? Do they have an infection? Do they get COVID, right? Do they get sick, pneumonia? They're laid up for a while because they're ill, and then unfortunately, they become more stiff and more difficult. It becomes more difficult to move around, and sometimes they don't recover all the way back to where they had been. So those kinds of things shorten their time in stage one, might bring them to stage two sooner because of other complications. Um, So it does say here, I didn't realize it said it here. Progression to this stage could take months or years. They could be in stage one with mild symptoms for years before it gets worse. Depends on the person. What we will see is difficulty walking. They may require assistive devices at that point, muscle stiffness, noticeable changes in posture, much more of a change in posture, and maybe even difficulty with speech. What I have observed is that the difficulty with speech tends to be not as much word finding issues, but slow processing. So, because their brain is processing, say, your question slower, they are much slower to answer. And they need us to give them more time to process the question they've been asked and then form the answer. Um, or given a direction, they need time to process the direction and even to sort of process it here, then send the signal to their body to tell their body what they need to do to follow that direction. So there's more difficulty with that. It's more processing than actually speaking words uh, with Parkinson's disease, at least until the dementia develops. Why my slides are being finicky. Okay, stage three. So I think of this right in the middle because we're looking at 5 stages. Greater difficulty with balance and movement. They may be independent, but they are more likely needing assistance with maybe getting out of bed, some of their daily tasks. They can still perform them independently. They take much more time than usual, much more energy than usual. So this is likely um, impacting their day-to-day life. They're not performing their normal morning routine as quickly as they used to get up and get out the door and to an appointment or an event or whatever. They may require help to do it quicker or help to just complete those tasks. Interestingly, this is when they mention life expectancy, and the symptoms of Parkinson's are not going to affect the life expectancy. So it's interesting. How is it not if there's all of this difficulty with performing daily tasks and moving around? Because those difficulties won't shorten someone's lifespan. The difficulties are happening, but they're not going to end the person's life sooner. What does lead to the end of the person's life is complications like falls with major injuries or infections, like I mentioned earlier. When there are complications that occur because of the Parkinson's disease, that is when the life expectancy shortens. Interesting from my perspective in hospice care, it's considered a life-limiting illness because Parkinson's leads to XYZ, falls and infections and complications that bring the person to the end of their life sooner. Those things would not likely have happened were it not for the Parkinson's, which is why the Parkinson's is the life-limiting illness. Okay. If you look into the research, and even neurologists will tell you that you won't die of Parkinson's disease, you will die with Parkinson's disease. It's not the Parkinson's that ends the person's life, it's complications because of it. Or because of the Parkinson's type dementia, then they have difficulty swallowing, they have aspiration pneumonia, those kinds of things. Okay. Stage 4, severe and limiting symptoms. This person is requiring assistance in all things, performing their own self-care, being mobile. They may need assistive device and assist of a person, or they may be requiring a wheelchair in order to be mobile because their coordination and balance and the tremors are just not working the way they want to. They cannot keep their balance and coordination because the tremors are too strong, the unwanted movements. Due to the increased risk of falls, complications may arise. And those complications also affect the person's quality of life. Not that all of these symptoms that come from Parkinson's aren't affecting their quality of life, because they certainly are. But having a fall, getting majorly injured, having head trauma from a fall, or a broken bone, hip, leg, pelvis, arm, collarbone, all of those things can really interfere in the quality of someone's life. And because they are likely aged, right, older, aged adults, their bones are more brittle, more fragile from osteoporosis and these kinds of things. So they're more likely to be hurt worse and take longer to recover, right? Okay. Stage 5. Debilitating symptoms. This person is likely wheelchair level. They are likely, maybe even a lift is used to get them to the wheelchair, because part of what becomes difficult with physically assisting someone at stage in late stage Parkinson's with transfers is that their body unintentionally, their body resists the movement. So I always think of this one gentleman, John, that I cared for years ago in the nursing home multiple times, that he came in to see us. And I was in an OT, and then I was his nurse after that. And he would be lying in bed, and in order to sit up on the edge of the bed, we would pull his legs over, right, and lift his trunk, but like from his shoulders, but his body didn't want to bend at the hips and sit up. It was almost like he was pushing back against us. It was like his body was purposely resisting us from sitting him up, and it would push backwards. We got to the point where we would get him sitting, and somebody would sit behind him, put a shoulder up against his back to keep him sitting at the edge of the bed, because he could not keep his body from pushing him down. So we would sit and hold him supported behind his back in order to get him up. So it's interesting from the medical perspective to see how the body it almost tries to fight everything the person is doing. And I think I talk about this with dementia also. It's important for us to remember that these clients of ours are not resisting us intentionally. They do want to cooperate. They do. They want to do better. They want to be mobile. They want to be independent. They want to be active. Their medical condition is forcing them to be less of that, but it doesn't mean that they're resisting us. And that's hard to keep in mind sometimes. I also found it interesting that they didn't mention hallucinations until stage 5 in this chart because hallucinations do happen earlier on in the disease. It does say 20 to 40% of clients with Parkinson's experience hallucinations and delusions, but the number increases as the disease progresses. So why didn't they mention it until stage 5? Because it can occur early on. Early in stage 1, your client may be having hallucinations. Some do, some don't. There are interventions for them, but we don't always, it varies when they begin. Folks, of course, in stage 5, having more difficulty moving are much more prone to injuries and infections, and the complications of those can be fatal. Complications, it's just another list sort of to make sure I have not missed anything. Thinking and processing difficulty, emotional challenges, swallowing difficulty. This often comes in late stage when they develop Parkinson's type dementia and the muscle weakness from the dementia is occurring and they're not swallowing as safe as they should. Their epiglottis isn't covering the airway properly, and food gets into the airway, and they have aspiration. Also, because of the weakness in the muscles in the throat, their cough isn't strong enough to clear the airway when something gets in there, so it gets down into the lungs and causes a problem. Chewing and eating can become a problem if the tremors, for sure, especially if they're in the head, neck, and jaw. That makes it more difficult to chew and eat properly. There may be issues with them biting their tongue or biting their cheek because of the tremors and the movements that they're not. I mean, your tongue is a huge muscle. If you can't control its movements, it's going to be difficult to chew and form a bolus and swallow like normal, like they normally should. Sleep problems and sleep disorders, often disrupted sleep, where if they may have difficulty falling asleep, but then difficulty also staying asleep, waking up throughout the sleep cycle frequently and not getting a good rest because they're not reaching that rest and recovery part of the sleep cycle, the REM sleep we talk about. So they're not getting that sort of energy buildup that we get in that stage of sleep that we sort of store up for the next day, also leading to more frequent napping during the day. Bladder problems and constipation problems occur also because of the unwanted or unintended muscle spasms, contractures, tremors. They're happening in the extremities, we can see. They also can happen to all the muscles internally. If the peristalsis of the intestinal tract isn't doing what it's supposed to, they're going to become constipated if the muscles aren't doing what they're supposed to move the waste through the pipes. Bladder, again, if the muscles aren't contracting and emptying the bladder like it's meant to, if they're doing their own little dance in there, they're never fully emptying their bladder. So what we see most often is not incontinence as much as retention being a problem with the bladder. Retention is a problem, incredibly uncomfortable, and often requiring a Foley catheter to be placed so that we just eliminate the problem of bladder retention. They may also experience blood pressure changes, orthostatic hypotension. So when their blood pressure drops when they change position, if they are earlier in the disease, they are having changes of their blood pressure, then they are more at risk of falling when they sit to stand because the blood pressure drops, they get woozy, they fall more easily, right? Smell dysfunction, interesting. Not COVID, but smell dysfunction, difficulty identifying smells can lead to lack of appetite because the food doesn't smell good, so it doesn't taste as good. Can also be something we notice where they are unaware of their own odors. Their body odor If they're soiled, they don't smell it like we do. Spills and stains on their clothes. So keeping in mind that things we smell, they don't necessarily smell. And in some cases, we need to, help to intervene so that hygiene is cared for better and that sort of thing, if necessary. Fatigue, I mentioned early on, from all the movement, absolutely, from the slow processing and the extra effort everything takes for our clients with Parkinson's. Everything takes extra effort. Just sitting in a chair to have a conversation with you, to have a meal, takes extra effort. So this is when I like to bring back Michael J. Fox into the conversation. That last interview he did on Sunday morning that I saw, there may have been one more recently, but he came in with a cane, sat in the chair, and he told the woman that was interviewing him that his movements were very strong that day. And he said, I can sit here and have a conversation with you and do this interview, but my body is going to move wherever it wants to. Or I can control my body, but I won't be able to have the conversation. He said it's one or the other. He basically had reached the point where my brain can control one thing or it can do the other thing, but you can't have both. He just could not keep his body still and hold a conversation with her. And he said that right up front, which I thought was amazing. In the past, he'd been able to, but he is no longer able to do that. So I think that's it was just incredible to have him just put it right out there, confidently and let us know. Pain from bumping into things, pain from falls and injuries, pain from the contractures, the muscle spasms, all of that can cause pain. We want to be closely monitoring our folks with Parkinson's and their pain levels and what is causing them pain and distress. And also to never forget that sexual dysfunction is another issue. Lots of muscles go into sexual activity. If there are spasms, if those muscles are not performing the way that they're meant to, there can be difficulty in that aspect of the client's life, and we should be addressing it. Don't ignore it because it makes you uncomfortable, because it is likely makes them uncomfortable, but also is leading to more depression and anxiety and fear and distress. We can address those things, so we don't want to ignore them. Okay. Let's take a look. Diagnosis. Genetic testing, yes. It is possible if it's hereditary. I'm going to hop over to the right. Disorders with similar symptoms. I mentioned essential tremors because in the very beginning, that's what it looks, it's very similar. But also, multisystem atrophy and Lewy body dementia have a lot of the same symptoms. When we are looking to diagnose, we need to make sure it's not one of those, and it is actually Parkinson's disease. So back to the middle here, non-genetic cases, if it's not genetic, the diagnosis is started with a neurological exam, a very in-depth medical history, and the last step to rule out for sure MSA and Lewy body is response to medication. Why? Because Parkinson's will respond to Parkinson's medicine, but the other diagnoses will not. We're going to talk about meds in one moment. I wanted to let you know because I found this fascinating. I'm very excited and I hope it continues. There is a new test on the horizon. There is a study right now being done of spinal fluid of clients that what is being found is these clumps of a protein in the spinal fluid, and that indicates Parkinson's. The folks without Parkinson's don't have the clumps of this alpha-synuclein protein in their spinal fluid. The dilemma is it requires a spinal tap. We don't want to tap anybody if we don't have to, right? If we can test another way and find out, that's better than doing a spinal tap. It is amazing to me that in this test, they found that this was almost 88% accurate. That's fantastic. But is there a way to detect this maybe in the blood instead of the spinal fluid? is there some other way to do this, right? To find these clumps of proteins and determine a blood test, of course, way more likely to happen than a spinal tap. So, the research is being done and it's a possibility in our future, which is fantastic. One treatment that you may have heard of, may or may not have seen anyone with, is a deep brain stimulator. That is an image here. This is like a textbook image. It was the best one that I could find. It's very simple. There is a power pack that is put subclavian under the skin, just like a pacemaker or defibrillator would be. The lead wire is run up under the skin, up to the top of the skull, and a probe is actually put into the skull, down into the brain to stimulate the basal ganglia. Stimulating it causes it to produce more dopamine, and it helps to control the unwanted movements. It's an amazing tool for those that can benefit from it. Whether or not you ever see someone with it is sort of up in the air, but it is an amazing thing that they have found is really helpful for some folks. So it's a great option for those who match. Let's see. Okay. Lastly, I'm going to show you the medications. I am kind of a nerd about meds and all the names of them, so I did break it all down. What kind of medication is it? This one here is a combination, but ultimately on the right side of the column is where you're going to see the names that you're most familiar with your clients taking. So the trial and error, I said, with diagnosing, testing the medication is testing a Parkinson's medication, carbidopa-levodopa combination. Carbidopa, dopamine, and levodopa, dopamine together, they found is the best combination to help control the unwanted movements. The names here on the right, Sinemet, Rilari, Duopa, and Inbrija, are different types, different combination meds of carbidopa and levodopa, depending on the client, depending on their insurance, depending on the availability of the medication, depends on which one they receive. I see Sinemet most often. I have for years. Sinemet is the one that I am most familiar with. You likely are too. The Duopa is an IV medication, likely not to be covered by insurance, so less likely prescribed. And Inbrija is an inhaled medication, so sort of a nasal inhalation. Interesting. I've never seen anyone with that's taken it, and I don't know how new it is, but I find that interesting. Always, if there's another route to administer medication, it's an interesting thing to find out about. So increasing the level of dopamine being produced by the brain helps the body control those unwanted movements, helps with the transfer of the neurotransmitter of dopamine between neurons and cells, and getting the message smoothly off to the muscles so that they are controlled. Other medications that we may see, there's a list. So the middle is the names of the medications, both the brand name and the generic name, as well as what it is used for. So Mirapex, Nupro, Apokine, these medications also stimulate the production of dopamine. They are oral tablets or capsules. The reason for the star for the Apokine is, I have to remember, hold on a second. The stars mean, oh, darn, I hate when that happens and my brain forgets. Tasmar causes liver damage and liver failure. I think Apokine is injectable. It's an injectable medication. It is a quick relief medication. It's not a daily use type medication. That's what it is. That's the caveat to that one. It is a quick relief of symptoms, but it's not a long acting or continuous use medication. The next two rows here, Comtan, Ongentys, Tasmar, and then the MAOBs in the bottom, they slow down the enzyme that breaks down the dopamine in our brain. So there's an enzyme that can overproduce, that can sort of overeat the dopamine, right? It breaks it down too much and too quickly, so the body can't use it the way it's needed. And these medications can help if that is the factor that's the issue as far as the dopamine production and use. Tasmar is has the 2 stars. It is approved for use, but it causes liver damage and liver failure, severe liver damage. So I cannot imagine that it's prescribed unless it is the final last possible option, but know that it is a possibility. Here we have Gocovri that helps involuntary movements. It helps to control involuntary movements. Gocovri, I think, is a newer medication that's been approved. Nuplazid helps with hallucinations and delusions. I still remember the commercial for Nuplazid, so I know that one's fairly new. Um, I have not asked any of you to interact with me, so although we are almost at time, I'm going to. Oh, that's okay. I completely understand the network being unstable. I was watching my face twitch there for a while. So that could have been mine. But what was I? I'm sorry, what was I going to say? The hallucinations. Let me ask you in these final moments, do we have to intervene for hallucinations? Do we have to do something about it? Do we have to medicate someone who's having hallucinations? Anybody with me still? Aaron, thank you. You saved the class. This reminds me of sitting in like social studies class and nobody knows the answer, and then one person finally answers. Thank you so much. So, no, we don't have to intervene, right? Thank you guys. I appreciate it. Um, I can see you. I appreciate it. Yeah. We don't have to intervene if they're not distressing to the person, right? Sometimes folks have hallucinations that are lovely, so we don't have to intervene. We don't have to stop. The commercial was a man sitting at an easel painting a picture of his golden retriever, and he looks down at the dog that he's painting the picture of, and then there's two. Not terribly distressing that there's another golden retriever there, right? They're lovely pets. Um, but for those folks that are hallucinating things like bugs on the wall or delusions, like people are watching and listening to them through devices, through the television, through the mirrors, there's all kinds of different things that the brain can do, unfortunately. So those are the types of hallucinations or delusions we want to intervene. They feel things on their skin and they're scratching and they're hurting themselves. Of course, we want to intervene. Those are distressing, right? And causing injury. So thank you. Um, then we have medications that can help with tremors and muscle rigidity. Sometimes muscle rigidity is more of the issue when it comes to bladder retention. Yes, bladder retention. So if rigidity is the issue there, then maybe one of these cogentin or artane may help. It can also help with digestion. They can help with the constipation issues. Um, and then Norian's here at the bottom is a medication that helps to allow more dopamine to be released by the brain. Okay. I think we just have, come on, slides. What are you doing? Ah, yes, prevention. So I don't have the best list of preventions, guys, because we're still learning. But the fact is, these, of course, are preventions for many illnesses, and most older adults should be using these preventions to stay healthy, to stay strong and active, to prevent any and all kinds of illnesses. When it comes to healthy eating, especially with neurological disorders, the Mediterranean diet is the one that is most highly recommended as um, um, a good healthy preventative uh, diet of intake of fresh, right? Fresh vegetables and cheeses and healthy oils, because although there's all kinds of, research out there that fats are bad for you, carbs are bad for you, they're not. They're all good for you in certain measures. Processed are not good for us. We know that. But healthy oils and fats are actually good for the brain. Omega-3 fatty acids, we hear about things, using um, my brain just lost it. not vegetable oil, but using things like sesame oil and avocado oil and things like that. They're good for us. So we want to be incorporating healthy fats and fresh foods as much as we can. And of course, protein, because protein helps our body heal. So if there's an infection, if there's an injury, protein is important for our body to heal. When it comes to exercise, Parkinson's disease in particular, there are some great programs, and you can look into them in your community. Some hospitals offer them, some community centers. I would contact my local council on aging or senior center if I, am looking for this sort of thing, or even, mm, no, I'm sorry. My brain lost what I was going to say. But there are programs we often in this area call them big and loud programs. And they have a lot to do with moving the body, big movements, lots of boxing, crossing midline so that they're working on their balance and coordination, lots of shifting. Dancing is a great exercise for someone with Parkinson's to dance with someone because they're shifting their weight from side to side and foot to foot and taking it off the other side. And what becomes the most problematic is that their coordination becomes poor. So when if they shift their weight distribution off a foot, they keep going, they tip over. The righting reactions that bring us back upright are what are failing the person with Parkinson's. So working the muscles in the body and the trunk and torso to keep them strong. The loud part of big and loud has to do with voice projection, which can be helpful because their voice can become a whisper. So working to project the voice. Avoiding falls. I think we're all avoiding falls. None of us really want to fall on purpose unless you get paid for it, right? And daily living activities. Continuing to participate and perform daily tasks as independently as possible is the whole goal. Doing what they can, whatever parts of their daily tasks they can do, and independently is what that we want to be encouraging. If it's only washing their face, they washed their face. If they're, picking out their clothes and they're not actually putting them on, donning their clothes, that's okay. They're still participating in making their own choices and doing tasks as much as possible. So the more they continue to do, the better. The sooner people give up things and let us take over, the quicker the disease progresses. So although we all want to be very helpful, we want to continue to encourage them to be as independent as they can safely. It's 11:01. I thank you all for being here. If you have any questions for me, please feel free to put them in the chat, or you can certainly unmute and ask me. Otherwise, I'm going to say go on with your day. Have a wonderful day. Enjoy it. I hope you're not in the really windy area. I'm getting wind alerts to my phone telling me that high wind is expected. If you're a surfer, go check out the surf. It's probably pretty good right now if it's getting windy. I'm a surfer, so I can't help it. Wind means surf, and we got to go to the beach. Thank you so much. I appreciate it. John, did we get all our names? Excellent. Excellent. Thank you, Cheryl.